So my trainee, Dr. Khan, is presenting a case that is known to home treatment team. We had her on and off since late summer last year. So she's going to present her and welcome your views and comments. Yeah, she's also known to Craigmont team as well. Okay. Okay, Dr. Khan, you can start now.
The case of a 60-year-old female, which was not known to the mental health services before August last year, but after that, she is aware of the mental health services and different services were involved, and she was admitted twice. So I have made, I have gone through her notes, and it is just a sequence of events what has happened, and I am presenting this case with a view that how we can do it differently, or what we can do to stop her future admissions. So she's a 63-year-old female. She was admitted with severe stress and adjustment disorder. She was diagnosed with ovarian cancer in March 2020. And she has a hysterectomy, oophorectomy, and a chemotherapy. When she was first presented the A&E, she had 2 chemotherapies at that time. She's currently living with her partner and in a 2-bedroom house. She's currently unemployed and receiving ESA, and she has 4 grown-up children which were involved in her care, and one of her daughter-in-law was also involved in her care. Her husband was previously working as a lorry driver, but because of her illness, he has stopped working. So first time she presented to A&E and she was admitted in the medical side of Hillingdon Hospital on 24th of 8/21 because of bilateral wrist laceration secondary to self-harm and suicidal ideation. She had right wrist tendon repair and left wrist washout, expiration and closure, and she was discharged from the medical side on 1st of September 21. Then on 31st of August, she was referred to psych liaison, and this was the first self-harm. She had, before this presentation, she has a hysterectomy 2 weeks ago. She feels scared and anxious about her physical health and prognosis. And she was accepted by the home treatment team. However, she was signposted for informal admission. On 2nd of 9th, 21, she was discharged to home treatment team, and she was started on metazapine 15 mg nocturnally. On 17th of 9th, 21, there was a phone call at 6:55 a.m. in the morning, and she said that I cannot handle this therapy. She was hyperventilating and said she was having a panic attack. On 22nd of 9th, 21, she visited Hillingdon Hospital. She requested for diazepam. And then on the same day, there was numerous phone calls from her daughter, and she was quite concerned about her mother. And she told the team member that she has to collect her mother from her own home and bring her to hers. And mother was calling the family members very anxious, and she stated that she wanted to kill herself, and she was very distressed. When she got to her house, then the daughter went to her house. Mother was holding a knife to her chest and she wanted to die. And the doctor was able to take the knife away. And so at that time, this was the call. And then she was seen again on the same day at 2300 hours in the A&E for panic attack, and she was requesting for admission at that time. And but admissions was not offered at that time, and she was sent back at home. So on 23rd of 9/21, next day at 11 o'clock in the morning, there was a phone call from her son that mother has taken all the medication which was given to her, which include mirtazapine and promethazine and some pain medication. And then the formal on 24th of 9/21, initially she was assessed for informal admission, but later on she was assessed for MHA and she was admitted under Section 2 after medical clearance. From 27th of 9/21 to 16th of 10/21, she was admitted in green ward, and later she was discharged to home treatment team. At the time of admission, her MSc was as follows. She was dressed in a nightgown, seems a bit anxious during the interview, took out her vape and smoked it. Her speech was a little bit fast and pressured. Her mood was that she was feeling anxious and depression, and there was no hallucination, no formal thought disorder. She had insight that what she did was stupid and that the amount of tablet would not have killed her. Then she was discharged on 16th of October 21 to the home treatment. She was to the home treatment team. She was supported by the home treatment team till 29th of October 21 to the CMHT, Community Mental Health Team, East. And then outpatient appointment was booked for her in January 22. There was in her notes, she used to smoke 40 cigarettes. Previously, she used to smoke marijuana on and off, but there was no regular substance use history. But before her outpatient appointment, she was brought to A&E by the London Ambulance Service following an anxiety for the last 3 days. And her symptoms were increased because of the non-adherence with medication. And on 10th of December, ambulance was called because she assaulted her husband unprovoked. And she stated that she was not feeling safe for the people and herself. And she kept saying that, take me to Riverside, last time I got better there. She was referred to FRT for admission and assessment for admission. On 11th of 12/21, around 3 in the morning, she was seen by FRT. She was discharged back to GP, and it was a plan that CMST to arrange for the talking therapy. On 12th of December, next day, family called London Ambulance Service again. They were unable to cope. She had hit her husband again. And according to her son, patient was dramatically deteriorated in mental state after the surgery. And son also reported that she jumped in front of a bus 2 months ago. No more information is available about this suicide attempt. And son also reported that mother is always being anxious and paranoid. Then on 13th of 12th, the cycle liaison called from discharge nurse reported that she has refused to leave the hospital after being assessed by the MHA team and deemed not retainable, and she was discharged back to GP. Then on 14th, next day, there was a call from her daughter-in-law. She was not settled at home. She was pacing and not sleeping well. And then she came to A&E, and family was insisting for sectioning, and then she was discharged to the care of, after the assessment, she was discharged to the care. She was not admitted. She was discharged to the care of CMST. On 15th of December, her metazapine was increased to 30 mg nocturnally. On 16th of December 21, she was seen by CMST team leader at home. He recommended informal admission. At the time of assessment on 16th, she was restless, agitated, pacing up and down, muttering that she was not right in head and she was not safe. She was scared of being alone. She was clinging to her husband, and when not clinging, she was pacing up and down. At one time, she sat on the husband's lap. She also said she was physically sick and observed holding her stomach area. So at that time, family was also concerned about the mental health. She was referred to first response team for gatekeeping, and she was also referred to central floor for bed management. On 17th, her husband called SPA. The SPA entry, according to SPA entry, despite asking several times what was the concern, he wasn't able to articulate anything that qualified as mental health crisis. So on 17th of the 12th, 21, she was seen by first response team, discuss available option, discuss available options, and the couple agrees for the home treatment team intervention, and she was accepted for home treatment team. During that time, there was a few times written in the notes that patient is asking for diazepam, and whenever the home treatment team member visit her home, she asks the first thing, "Have you brought my diazepam?" And because of the concern that she was using diazepam, she was referred to the rest team. There was also one occasion when the patient called and she told the home treatment team that her son has thrown her medication in the toilet, and she needs all the medications again. On 19th, 3 in the morning, the telephone call was received from the husband that the patient is restless, and then again at 7:45 in the morning, there was a telephone call from the husband that she's pacing up and down. She was seen by the London Ambulance Service. Temperature was slightly raised, 38.1, and she appeared anxious and restless, pacing about the house. She was transported to A&E for medical checkup. Then again, on 19th, she was seen by the HTT team at 1500 hours. The plan was to visit that afternoon with promethazine. On 20th, there was a call from London Ambulance Service at around 8 in the morning that the patient was anxious, restless, and pacing in the house. Then on 20th, she was seen by home treatment team in A&E. She stated that promethazine is making her feel worse. And she also stated that she got agitated at her husband and tried to attack him. The home treatment team spoke to the husband on phone, who confirmed that she was being aggressive and that he had pushed her away a few times during this. She sustained some bruises on arms. At that time, safeguarding concern was also raised. On 20th, she was discharged, and she was seen by STT in home visit. On 21st, she was seen by the rest team, and Westry team said that, at that time, they recommended refer her back to the STT, and they felt that rest input was not required at that time. And then again, on 22nd of December, around 1:30, there was a telephone call from her son that she's anxious and she's pacing up and down, and she wanted to bring her to A&E, and but he was reassured that the STT will visit in the afternoon. On the same day, around 5 p.m., she took the overdose, and she came to A&E. She took the overdose of Cocodamol, 7 tablets, and came to A&E with the overdose. On 22nd of the 12th, 21 at night, she was reviewed by the first response team for informal admission. She was seen for the MHA assessment, and informal admission was suggested. And on 23/12/21, she was admitted to pain ward. She had around 3 to 4 falls in the ward. She declined to go to A&E, and she declined to be examined by the doctor. On 4th of January 22, urgent MRI lumbar spine was requested. And 21st of January 22, venlafaxine was started along with metazapine. On 2nd of February 22, she was discharged from the ward. After the discharge from the ward, the MRI report showed that in the left femoral greater truncheon and lower femoral neck IT fracture, there's a widespread moderate marrow edema with underspaced fracture line extending along the greater truncheon to the lower femoral IT region posterior medially. So she had a fracture, undisclosed fracture, and she was requested to come back to A&E. She came back to A&E, and then the A&E managers conservatively they didn't send her for any intervention. And on 16th of this month, 16th of last month, she was discharged from home treatment team. So this is the brief summary of the notes. And if you have any questions so far, you can ask.
Hi, this is Bikram. I am a specialty doctor in the memory service. You mentioned she's 63 years old. What ethnicity is she?
I think she's a white British.
Okay, thank you.
There was at one time by the rest team, the concern regarding memory was also raised that, but at that time she was quite anxious, and otherwise in the rest of the notes, concerns about the memory was not raised. There was a concern about her diazepam, and she was asking for diazepam in between. She's quite anxious, and our team is also concerned that this thing happens before, and before the next CMST, she might come back again. She was also referred to the health psychology for the input, but the health psychology suggested to refer to the psychology team of CMST to give the input.
Hi, I'm Kim from Frey's ward, Dr. Sabir. May I ask why a lumbar puncture was indicated? What are the symptoms? Did she present with fever? Is just that fall which caused you concern and lumbar puncture was indicated? I wasn't very sure.
Yeah, lumbar puncture was not done. MRI was done. MRI lumbar spine was done because she was complaining of pain. She had a fall. That was the reason MRI was suggested. And during that MRI, they found out IT fracture of the hip.
And was it due to fall or was it due to other pathology?
It is difficult to say that is it due to fall and or is it due to other pathology. But as far as on the discharge summary and on the feedback I received that they decided to manage it conservatively and they didn't send her for surgery.
Okay. So obviously these distress are caused by most of the physical symptoms for the 68-year to cope with.
Yeah.
And she felt suicidal and irritable.
Yeah.
Okay.
Another thing which we have noticed is that she was referred to different teams. They were asking for admissions and it felt that admissions were delayed. And then she presented with self-harm and then she was admitted.
It's very sad, yeah.
Hi, Rashid, it's Barry, one of the GP trainees. It sounds like a lot of her stress and anxiety was largely related to her physical health. So the recent diagnosis of ovarian cancer and the fact that she underwent this kind of extensive, hysterectomy, oophorectomy, and then she was having chemo. In all those times that she had come to A&E, it seems that there was multiple presentations. Did she ever mention having any support from the Macmillan nurses? Was she being reviewed by the oncology team? Were they kind of reassuring her that things were, from a prognostic point of view, were things, going in the right direction, things to reassure her? Was there anything like that at all?
Yeah, it was mentioned that she was referred to Macmillan nurses for support. But I think it is not mentioned that how much support she has received from Macmillan nurses. At the time of discharge, first time from the crane ward, she was also referred for carer support, but she declined for it that because her husband is at home, so she doesn't need any carer support.
Yeah, I think with these other kind of support services, I think it also depends on how much she wants to discuss with them as well.
Yeah.
But yeah, there must have been. I'm assuming that's probably one of the things that's why she's so anxious as well, is because she's worried about the underlying cancer, whether it's actually been treated or not.
Yeah.
I think if you notice as well, the other complicating factors, there is some kind of abuse going on, domestic violence, and safeguardings were raised on several occasions. Also high stressed emotions, the family, suspicion of substance misuse, not only on her part, but the family as well. Frequent requests for benzos and then benzos disappear from the house, claims of flush down the toilet. There's history of her being dependent on amphetamines. So there's all these complicating factors and family dynamics. Her partner is not the father of her son, and there is conflict between them. She was seen with bruises, and then her husband would claim that she assaulted him. So there's all these factors, and which made the treatment also even more complicated and unpredictable.
Sorry, this is Pooja, consultant for Orlando CNHT. So you mentioned temperature at some point when she was taken to A&E. Was that a red herring, or was there any significance of that at all?
Yeah, that was not significant, and she was seen in A&E. She was medically cleared. They were suspecting that she has UTI, but her urine sample was cleared, so they medically cleared her, and then she was discharged.
Thank you.
All right. Thank you. Any other questions?
Yeah, hi, this is Jovita. Hi, Matt. I wanted to ask, what's the outcome of the safeguarding then? What did that?
Yeah, safeguarding was later closed during her second admission in train ward. So, I don't know the detailed outcome.
Yeah, so no action really was taken. She was just discharged back to the matrimonial home, and nothing really happened out of that. So.
I don't know if you've answered this before. What's the family dynamics like? Because it seems as if she's, repeated calls to A&E, assault on the husband, things about medication. Do you have an overview of, the family dynamics at home? The husband, I think it's the daughter that is involved, kept calling, isn't it?
Yeah, daughter was involved, daughter-in-law was involved, son was involved. And on several occasions, it was noted that family is too much involved and they were insisting on admissions.
So is it diagnosis still acute stress reaction that adjustment disorder, or did you guys change the diagnosis?
Diagnosis remains the same, that adjustment disorder with the depressive symptoms, and because she was receiving chemotherapy.
Okay.
Sorry, I might have missed it. I stand for one of the CT2. Just wondering, what was the result of her last head scan again?
Head scan was not done. I'm not aware of the head scan.
I see, just thinking because of her age and also because of history of cancer, just thinking any organic cause to be ruled out necessary or not.
So far, so good.
Yeah, that's important that CTA or MRI was not done, and because she was medically cleared in the A&E, but it was not done from any of the team.
Thank you.
I think it would be nice to, just probably, she's on that CMH now, isn't it? Just explore more the family dynamics, because what does it mean for her to have cancer in that family? Is she, happy playing with the sick role of, because before now, things were okay.
Yeah. There was an element of substance use also, like cannabis. It was mentioned at one time. It is mentioned that she had used amphetamine also. She had worked as a bartender, so we don't exactly know that what is the family dynamics before that. Son mentioned that she's always been anxious and worrier. Whether it is her personality which has that she get more anxious because she has anxious predisposition, or the family get panic or what happened. Yeah, this is something which could be explored.
Well, probably psychology then I would have thought so, just to.
Yeah, I mean, that's why we try to refer her to the health psychology. We were wondering because she's cancer survivor, obviously, and we were hoping that she would be offered health psychology, but we contacted them and they said no, they're not going to offer that, and needs to come from the CMHT. So that's why she's under the CMHT for mainly for psychotherapy. So hopefully this will, find out more about the family dynamics, and also because of her recurrent presentation, repeated recurrent admissions, recurrent presentation in crisis. So that's why she needs kind of long-term support. I mean, I think the diagnosis clearly needs reviewing. I think we inherited that from the liaison team and from the wards, and that's sort of something that I think doesn't explain all her symptoms.
Yeah, exactly. I totally agree with you. That's why I asked that, and I think it will probably, now that she's within the CMHT, they can explore what interventions she did. It's just acute stress reaction in secondary care.
Yeah. I think that's another theme as well.
Max, you know my views about that.
Not a criticism to anyone, but I think we get discharges, and we would expect people coming from the wards or the CMHT to have a diagnosis, and then it becomes something like it just goes on, and the patients move around with the same diagnosis they had initially when there's something we should look at. And especially she's now on 2 antidepressants, which may be qualified for treatment-resistant depression. And also, being under the CMHT with depression, I think it's more becoming more treatment-resistant depression. Yeah, thank you. Any more questions? From anyone? Psychotherapy, exploring family dynamics, and maybe liaison as well with the cancer team, with the oncology regarding metastasis or any complications. Yeah, does that summarize all the? Yeah. Okay, thank you. So I take it no more questions, yeah? Yeah, all right. So we will send the slides. I think some people requested the slides, so